And so I'm constantly back on my heels trying to keep up with everything. I'm never bored. It's never tedious for me.
Dr. Ed Uthman, how you doing tonight, my friend?
Doing great. A little frozen here in Houston, but otherwise fine. Still have electricity.
Yes, the frozen tundra of the United States as it's going right now. We've been in negative digits here in Colorado. Luckily, it looks like it'll thaw out the next few days.
I hope so. But y'all are used to that. I mean, you can handle it. We can't.
We're not usually used to negative weather, but luckily it's only lasting a few days. But I'm glad the power held out for you, and hopefully everyone, almost 1,000 students watching with us are warm and tidy in their houses tonight to talk about anatomical and clinical pathology. Let's chat about anatomical clinical pathology. What is that in the world of medicine?
Anatomic pathology is what most people think of when they think of pathologists. From TV and the media, you think of doing autopsies. Probably only about 5% of pathologists do autopsies routinely. Most of what we do in anatomic pathology is interpreting biopsies, cytology specimens, and excised surgical specimens. Clinical pathology is when you think of the clinical lab, that's clinical pathology. So the subspecialties within there are hematology, chemistry, blood banking, microbiology. Those are the main ones. And then there are other things too that kind of offshoots of those, like immunology, molecular biology. Those all are part of the training of the clinical pathology experience. It's one of the most diverse specialties that you can get into in terms of your knowledge base.
Are the TV shows good for your specialty, or are they bad? Does it add more confusion and kind of misunderstanding of what pathology is, or is it cool that it's getting people interested and then you got to educate them a little bit more?
Well, it's like most things in the media. It's a mixed bag, and I mean, I love drama. I love movies and TV shows, and I understand that writers have to create drama.
Yep.
It seems like more often than not, the lab people are kind of at the short end of the stick. You know, the lab makes errors. The people in the lab are weird. They're in the basement. They're doing all sorts of things in the middle of the night that nobody's supposed to be doing in the hospital. Things like that. So, but it's a mixed bag. And I mean, they do that to all the other specialties too. So
yeah,
I'll take my share of it.
Very cool. Talk about the journey to become an anatomic and clinical pathologist. What does that training pathway look? How long does it take?
Well, for anatomic and clinical, which most people do in the U.S., it's a 4-year residency. In practice, to get a good job with a well-established group and to be put on a partnership track, these days basically everybody that my group has hired in decades has done at least 1 year of fellowship. Some people do more than that. A fellowship's like a subspecialty year. In some cases, it's like a 5th year residency, and you just do surgical pathology, which is examining biopsies and stuff, for an extra year. But then you could also do them in hematopathology, and that's actually a 2-year fellowship. And there are fellowships in dermatopathology. That's another popular one. And all the other subspecialties you can do fellowships in.
It's interesting.
Once you do that, then you can take the boards after 4 years, and then you become board certified. Yeah. And then after you finish your fellowship, you can get on the marketplace.
So it's interesting. A student just mentioned, reminds me of jokes about pathologists finding the cancer and the oncologists getting the credit. How is it for pathologists? Because a lot of pathology, right, there are pathologists who do interact with patients, but a lot of it's behind the scenes, diagnosing slides and passing that information on to the care team who actually gives the diagnosis to the patient, comes up with a treatment plan. Does it take a certain someone with a certain temperament and kind of skills and traits to be okay being behind the scenes like that?
Yeah, you have to accept the fact that a lot of people don't know much about what you do, but I think it's really in your own hands. I mean, if you want to stay behind the paraffin curtain, as we're talking about it, you can do that, and a lot of pathologists do, and they're very happy to come in and work their 8 hours and go home and pick up their paycheck, and there's absolutely nothing wrong with that. But there are other jobs, like I'm a pathologist in a community hospital. I'm the only pathologist in that hospital. I have to cover all the services, I do a lot of committee work, a lot of public relations work, and I also interact with patients quite a bit. My phone number that I put on all my reports is my direct number. Unlike any physician in the world, you can call me directly. A patient can call me directly.
That's brave.
Yeah, no, yeah. And but so few take advantage of that it doesn't overwhelm my time, and I'm happy to talk with them. And I think it's best for physicians. The more physicians interact with the patient, the better off it's going to be for both of you.
Yeah. Very cool. And just for everyone watching, I'm wiping my eye with a little cold compress here. I got some allergies, I suppose, killing me today. So just ignore me. The show must go on, as they say. Luckily, you're not here for me. You're here for Dr. Uthman. Let's chat about bread and butter. It's a topic I like to talk about, things that students really need to understand. What are the quote-unquote boring things that you have to do day in and day out as a pathologist, right? Talking about media, the TV shows like to show the really cool cases, but that's not, for the most part, what a practice looks like. So what's bread and butter for you as an anatomic and clinical pathologist?
Well, fortunately, I've got probably the best job any pathologist could have because I get specimens from a lot of different venues and different parts of the body under different scenarios. And so I'm constantly back on my heels trying to keep up with everything. I'm never bored. It's never tedious for me. But if you are a uropathologist and you work in a urology lab, uropathology lab, you may sit there and look at, a dozen 16-part or 15-part prostate biopsies all day, and that's all you do. I don't think I could do that, but obviously there are people that do it and like to do that. And you just have to know going in what each type of pathology job entails, and don't get yourself in the wrong one. And sometimes you do get yourself in the wrong one, but it's never something you can't correct. In fact, the job that I've been in since 1986 was my fourth job. So the first three, for one reason or another, usually family locations, that didn't work out. But then the fourth job turned out to be great.
Yeah. As they say, you have to kiss a lot of frogs, right?
Yeah, I guess. I don't know. I probably could have been a little bit more selective in my earlier jobs, but everything worked out. I don't have any complaints.
Yeah. Do you think that's just part of the process of learning who you are and what you want to do eventually, whether that's seeing the same thing over and over again and being the expert in that one thing and working in an academic environment so you can research that and write papers about that, versus someone who's a little bit more of a variety junkie and can't see the same thing every day?
Sometimes I dream about that. When on a day when I've had to get a textbook down like 10 times to look up something I've never seen before, I'm thinking, wouldn't it be great to work at MD Anderson and do just GYN path and know everything that's ever been written about every disease of the female genital tract? That would be awesome.
Yeah.
Then I thought, kind of like what I'm doing. I'll keep reading the books.
I like what I do. Yeah. Keeps you on your toes. Well, that's awesome. Well, I'm excited. I know the students love cases. I'm excited to jump in with into some cases with you, and then I'll keep a look at the comments to see if there's any questions that come in for you.
Okay. So this is a young woman that came in with an enlarged uterus, and on ultrasound, she had a positive pregnancy test, and when they did her serum beta HCG, which is the quantitative version of the pregnancy test, it was really, really high, very high, much higher than you see in normal pregnancy. So when they looked at the uterus with the ultrasound, they did not see a gestational sac. They saw a so-called snowstorm pattern. So typically what happens in this case is they do a suction curettage, and I get a specimen that's not really memorable. But in this case, for some reason, they did a hysterectomy. So I got the very first time I've ever seen this in a hysterectomy specimen. So when I got it, it was a large boggy uterus like this. This is an external view. So this is fresh. It's not fixed. So there's still a lot of blood there all around the table. When I cut it open, I did not see anything that I expected to see. And when you look at this, so here's the outside surface here. Here's what was inside the uterus. And when you relieve the pressure on the uterus, all this stuff just came out. And it kind of looks like some bizarro version of a bunch of grapes. And when you go down close to it, and when you have time to take some really nice photos, you see they really do look like grapes.
They
So
look
you
like
see
little
these
fluid-filled
vessels.
sacs.
That's right. That's exactly what they are. And you see there's still some kind of stringy things that you say, well, maybe those are placental villi. And then you would hypothesize that, yes, they're placental villi, but they're way too big. And in some places, they've swollen up to be these balloon type things. And you can make the diagnosis on the gross in this case. But we do a microscopic exam anyway. In this case, we see placental villi, which is what these are, but they're markedly expanded. Like a normal one would be like this size. So this is what we're seeing here. And it's so edematous that it's actually completely lost all the tissue, and that's just like a lake of fluid in the center. Another finding that we see that's characteristic of this lesion is that this is a villus that is big, not as big as those others. Normally, you have just a little rim of trophoblast around each villus, but in this case, the trophoblast is proliferating. You shouldn't have this much, and it goes all the way around pretty much. So with this, we make the diagnosis of a complete hydatidiform mole, which is a crazy, horrible, weird, kind of science fiction-y kind of error in reproduction and fertilization of the egg. So what usually happens is a sperm comes in, and it has to be an X sperm. A Y sperm won't do it, but an X sperm will come in, will fertilize an ovum, and at some point the nucleus, the female pronucleus, maternal pronucleus, degenerates. So the only genetic material is paternal. And if that genome duplicates, so you end up with 2 X chromosomes, or in the case of, you can actually get 2 sperm going in, you can have 2 X's or an X and a Y. You end up with something that's 46XX, and the genome is totally of paternal, the father's origin. That cannot produce a viable fetus. It doesn't produce any kind of fetus or embryo at all. All it produces is a bizarro placenta, which is
is that a real medical term, bizarro?
Yes,
does that go in your reports?
It is a real term. Only I use it, but it is real. But yeah, it's a. I mean, when you first learn about these in med school, you're thinking, "What, man? Are they pulling my leg or something?" But that's exactly what happens. And of course, the woman may think she's pregnant. Turns out she's not. And of course, that's a big disappointment to her. But the danger of these is, if they're not treated, they can persist and actually turn into a neoplasm, can turn into a choriocarcinoma. So the way these are treated, you almost never have to do a hysterectomy. This is the only case I've ever seen with a hysterectomy. They evacuate the uterus, and then there's a tumor marker, serum beta HCG. You just follow that for a period of months. And if it never rises again, she can go back to normal reproductive life. And even if she does get choriocarcinoma or chemical evidence of same, it can be treated very successfully with chemotherapy. In fact, this was probably one of the first solid tumors that chemotherapy was found to completely cure.
Wow.
So most of these have a happy ending, but they do have to be followed.
Wow. Just for some definitions for those watching who may not know, what you talked about gross, and I think a lot of students who don't know the terminology will think you're describing using an adjective of what you're seeing, but describe that term gross in terms of pathology.
Yeah, gross just is German for large, so it describes those findings we can see with the unaided eye. So you don't need a microscope to see them.
Yeah.
So when you get a specimen, the first part is the gross examination, and then you either look at it, the whole thing microscopically, or portions of it microscopically, and do the microscopic examination. Yep. And from those findings, you get the diagnosis.
Very cool.
But pathologists do use the term gross the way normal people do too, so it's all about context.
Smells gross, looks gross, is gross, and then microscopic.
Exactly.
Yeah.
Okay, this is case number 2. This is a middle-aged man who came in with massive hematemesis, or he's throwing up bright red blood. Hard to say. And by the time he came in, he was already pretty anemic. Don't remember if he was shocky or not, but he was in pretty bad shape. Had to go straight to surgery. And they did a partial gastrectomy. And So this is an open view of the stomach. You're looking at the mucosal surface or the inner lining of the stomach. This is what the normal stomach looks like here. Has this rugose pattern. And when you look at it closely, it has kind of a velvety look to it because of the architecture of the mucosa. But so all this is abnormal. And this looks like hamburger meat here. So this is a huge geographic ulcer, and that's where all the bleeding was coming from.
I'll never look at hamburger meat the same. Thank you for that.
Yeah, and of course in pathology, we're known for describing findings in terms of food, because food is something that people encounter that's organic and biological material, so it's convenient, but it does tend to gross people out. So looking at it with the routine stain that we use, we start off with every case is hematoxylin and eosin, H&E stain. That's our routine stain. So this is actually part of the submucosa. You're not seeing the mucosa here. You're seeing the part of the layer underneath the mucosa. And there's some blood vessels here. This is a blood vessel. And instead of the normal walls, there's this waxy pink stuff here. And what is this? So presumably what's happening is whatever this pink stuff is built up in the vessel walls and has made those incompetent, and it has caused necrosis of the overlying mucosa. And then because these vessels are incompetent, they bleed, and the patient presents with throwing up blood and gets in pretty severe situations. So from the routine stain, I think I probably knows what this is, but we got to do a confirmatory stain. So we could do something called Congo Red. And Congo Red stains these vessel walls red, but that's not the diagnostic test. We actually have to put this under crossed polarizers. We're going to look at these vessel walls again with the polarizers on it. And you still see the blood vessels, but instead of the colors before, you see this apple green birefringence. It's called birefringence. And it's the light that gets through the polarizers. Mm. And so this is a case of gastric amyloidosis. I've seen them in biopsies before, but I've never seen a patient present with massive acute surgical problem like this and get a whole stomach for it. So this probably gave my lab enough Congo Red control tissues for the next 100 years or so.
How often do you get to write up cases for journals and stuff?
I did early in my career. I started off in academics, and I wrote up whatever I could. Once I got into private practice, I cooperated with some other people doing things, but I don't recall ever having written up a case report. Show them to friends and show them at meetings and stuff like that. But the thing is, almost everything has been described. That's what's really weird.
Yeah.
You think, boy, I bet nobody's ever seen this before. You start digging, and well, there it is.
Yeah.
But so this is gastric amyloidosis here.
Yeah. Amanda, I think it was Amanda. Amanda, I think, guessed amyloid before you said the diagnosis. So
she nailed it. Absolutely.
Someone said it.
I wonder if she caught it on the gross, though. That would be really impressive. So this is a case that the people I want to see this one, not just people that might become pathologists, but those who might become surgeons or gynecologists, because there's a real big lesson to be learned in this one. So this is a young woman that went in for a C-section at term pregnancy, and the obstetrician found 2 markedly enlarged ovaries and removed them, thinking that they were neoplastic, that they could be cancerous. This is a woman still in reproductive age, and now both ovaries have been removed. And grossly, they are large. You can see they're bigger compared with normal ovaries, and they don't have the normal architecture either. They're these brown nodules, and separated from each other by this off-white to yellow material in between. Ovarian tumors can be solid or cystic. This is clearly a solid one. Look at one of these up close, and you can see these brown lobules. So if I'm looking at this grossly, if you just handed me these grossly, I'm very concerned that this could be a neoplasm. If you told me with no history. But when you know the history, you know what they are. But let's look at the microscopic. And microscopically, this is the routine stain, the H&E stain. And you see individual cells that with nuclei that are small and round They're not pleomorphic. The chromatin contents very finely divided and even. They just look really benign. The nuclear cytoplasmic ratio is small. The nucleus is small relative to the cytoplasm. These look very benign. And if you took a close-up of a normal corpus luteum in an ovary during the secretory phase of the menstrual cycle, it would look just like this. Of course, it'd be a different shape. It'd be the shape of a corpus luteum. But if you look at it closely, it looks just like this. But this is a big tumor that had all this. So that's certainly not normal. I think I know what this is now. And now also knowing the history, but I'm going to do some confirmatory stains. And one of the things that we use in anatomic pathology is immunostaining. And this allows us to actually identify anagenically determined substances on the surface and inside cells of the specimen we're looking at. So we can stain for specific chemical structures, chemical components. And so this is an immunostain for inhibin. It uses a brown chromogen. So all these cells have brown to some degree or another. So this is positive for inhibin. I did another confirmatory stain. This is called melon A. It's a stain that we use for melanoma. This one has a red chromogen, and it's strongly positive too. But melon A is also positive in a lot of other things. And when you put it all together, you end up with a diagnosis, which turns out to be kind of good news and bad news. The diagnosis, these are luteomas of pregnancy. These are not neoplastic. They resolve spontaneously after the end of pregnancy. So once she delivers, they go away. So the lesson is what I want everybody to remember. If you're ever in a pregnant woman's abdomen and you see markedly enlarged ovaries, just step back, don't panic. They're probably luteomas.
So here's the question, right? To me, this screams like malpractice in an otherwise healthy woman who is of childbearing age, and the OBGYN freaks out and takes out ovaries, and now this woman can't have any more children.
I don't know the total clinical context.
Yeah.
I mean, I really don't. And I can't imagine that the gynecologist would have taken them out if there were not a permit to do that already.
Yeah.
So there may have been some reason to suspect this was a neoplasm, but it wasn't. The way to handle it, I mean, the most you ever do, if you see bilaterally enlarged solid tumors in a pregnant woman, the most you want to do is take out one ovary and send it for pathologic exam.
Yeah.
If it turns out to be cancer, then you have to assume the other one is too. But you don't want to take out both ovaries on a pregnant woman with a bilateral enlargement like that. So this is another case of something that isn't what it first appears to be clinically. So this is a middle-aged woman with chronic renal failure who came in with a deep mass in her buttock, or I guess probably hip or buttock, somewhere in that area. And the surgeon went in and resected it. The specimen grossly I've never seen one of these before either. This was new to me, even though I'd been in practice for 30 years when I got it. So it was this mass that had kind of a gritty feel to it. And when you cut into it, I'm showing it here as being full of these empty cysts or collapsed cysts. But when I got it fresh, these cysts were filled with this creamy pink stuff. It looked like Pepto-Bismol. Totally, I've never even seen it described. So I had no idea what this was. So this is what I definitely, because when you see a big, ugly mass like this in the deep soft tissues, you're going to be worrying about a sarcoma, which is, of course, really bad news. Yeah. That's a malignancy of the connective tissues. So we go to the microscope on this one, and it becomes pretty easy at this point. So this is a low power view. The first thing you see is these sinuous, opaque structures here. Normally when you see them under the microscope, they're dark blue. This one, they have more of a red color to them, and I don't know exactly why that occurred in this image. But the texture is pretty distinctive. When you go up a higher magnification, you see this amorphous, opaque material, and then a lot of cells around it. These turn out to be just histiocytes reacting to this material as foreign material, and some fibrosis. This is fibrosis around these islands of this material. what this material is calcium salts, inorganic calcium salts. And this is a case of calcinosis of chronic renal failure. It's also pretty rare. All this stuff I've shown you is really rare tonight, but instructive. Calcinosis of chronic renal failure. See, what happens in renal failure is one of the things that the kidneys, if they're not working, they have a hard time excreting phosphate in the urine. So the body retains phosphate. That drives down the concentration of calcium, which stimulates the parathyroid glands to increase the level of calcium in the serum. And that's called secondary hyperparathyroidism. And what happens is if you have too much calcium and phosphate together, they will precipitate out. And in some cases, as in this case, they form a mass, which clinically could be indistinguishable from a sarcoma. So in this case, the thing was removed, not really knowing what it was, but it was easy to make the determination, especially when we had the history of long-term chronic renal failure and a patient being on hemodialysis. So this is calcinosis of chronic renal failure.
That's an interesting one. How often do you get to a case that intrigues you? You're like, oh, this is interesting. I haven't seen something like this forever or in a long time. Or because you've been in practice for so long, is there really not much new that you've seen?
You would think, but no, it's at least twice a week I see something I've never seen before.
Cool.
Yeah. I mean, there's so much stuff. I mean, like, one of the things I want to say about pathology, if you like books, if you like reading, pathology is a specialty to you because we are the most bookish doctors. We have the most books of any doctors. I spend thousands of dollars a year on textbooks. I have a huge floor to ceiling bookshelf in my office, and I'm constantly, I'll buy a book for $400. 4 years later, I just throw it away because it's no longer any good.
And they're picture books, so you don't even have to like reading.
That's right. Yeah. You see, I mean, normally what you do is you go and look for a picture that matches what you're seeing, but then you have to read about it because there's always a bunch of ifs, ands, and buts. You have to go through a differential diagnosis.
Yeah.
There are so many ways Mother Nature can fool you too.
Yeah. How much are you using technology as an adjunct to help you nowadays with machine learning and AI, with Google and all these different big tech companies getting involved and helping read slides? How much are you using that at this point, or not at all?
It's it's still kind of experimental using AIs to read slides. My generation is not going to have to worry about being replaced. I don't think the next generation is either. I think the thing is to program a computer, you have to know what you're programming it to do.
Yep.
And pathologists don't know how we don't know how we make most diagnoses.
Yeah.
We just don't. And people try to do it, but so far has not been made much impact. We do use molecular techniques a lot, but they still require the conventional pathology examinations before you even employ the molecular techniques.
Yeah, very good. I cleared out the raise to speak. If you want to raise your hand to come on and say hello, you can do that now. Dr. Uthman, what is the most memorable case that you've had?
I don't know. Some of them are, really tragic. I remember when I was a resident, the forensic pathologists, the county medical examiners who were in the same building with us, referred me a case of a little 4-year-old girl that they thought she had some violaceous areas on her abdomen. They thought she had died of meningococcemia, which can produce those kind of skin lesions. And when I opened her up, blood just came everywhere. And she had a liver that was completely torn in half. So it was a child abuse by blunt trauma. And you don't forget things like that.
Yeah.
And that was back in the 1977.
Wow. Yeah, that's definitely a memorable one. Hannah, unmute, say hello.
Hi, can you hear me?
I can.
Hi, I'm interested in pathology, but I'm not sure of the different kinds of pathology medically. Not forensic. If you could tell me.
Right. So in the U.S., most of us train in both anatomic and clinical pathology, and take boards in both of those. And depends on where you want to practice as to how focused you get. If you go to your university, you may do not only just anatomic pathology, but you may do just breast pathology or just urologic pathology. They're highly subspecialized. Or you can get a job like mine and basically be responsible for everything and constantly having to look things up. So there's all sorts of opportunities within the pathology field. Very diverse, and just depends on your personality.
Thank you.
Lots of options. That's what I love about medicine is once you have that degree, there are just so many possibilities for your future career. You can do what you want. Denisha.
You had it right the first time.
Denisha. Hello.
Well, I actually wanted to ask a question, then share my story. Recently, I just had surgery. I had a cystectomy and I had endometriosis in my ovaries. Um, my doctor, he didn't really tell me as much about it, but it made me more interested and wanting to pursue pathology as a career. So do you have like any pointers or any tips?
Well, about endometriosis in particular.
Yes, and like like cysts and how they come about as a like diagnosis.
So endometriosis is one of those lesions that makes masses, but it's not cancer. So what it is normal benign endometrium, not cancerous endometrium, gets explanted to different parts of the body. And typically they're down in the pelvis. They often involve the surface of the uterus or the ovary or the fallopian tubes or the broad ligaments. And if that endometrium is normal, it will cycle just like the normal endometrium lining the uterus. And if it's sealed on itself off, it will form into a cyst, and you end up with these enlarging cysts that grow and subside with the menstrual cycle, and they can be quite painful.
So is that why I had this? Well, so could the endometriosis trigger the cysts that are in my ovaries?
Yes. I mean, that is one of the manifestations of endometriosis. They're these cysts that when you cut them open, there's old blood in there and it looks like chocolate. They're called chocolate cysts.
Yes, I actually seen that also on my picture.
Oh, okay.
Yeah. Okay. Well, thank you.
Well, thank you. I hope everything goes well for you.
Thank you.
Brandon.
How are you guys?
Good. How are you?
Hi.
Good. Quick question. I have recently discovered as I continue my undergraduate journey that I have a love for microbiology that I never knew I had. And I even have my own microscope and everything. My wife makes fun of me all the time because it sits on the kitchen counter or the kitchen table.
Sounds like a future pathologist.
Yeah. So I was just wondering when you knew that pathology was right for you, and if you chose the specialty, or what caused you to want to take that route?
Well, I've always wanted to be a doctor from when I was 8 years old, and I got fixated on it. I read anything I could about medicine in the popular, like in Reader's Digest and stuff like that. I watched every medical show on TV. And all the way through senior year of medical school, I was planning on being a primary care internist. That's what I really wanted to do. But when I started to take electives in internal medicine, I realized that what I really enjoyed was the detective work involved in the diagnosis. And once I got the diagnosis, I just kind of lost interest in the case, because then it's about following cookbooks and prescribing this or that drug. And you also have to deal with they don't teach you this too much about this early in medical school, is all the social issues that the patients have. If you're a pathologist, most of your clientele is doctors. And if you tell a doctor a diagnosis, they act on it right away. If a clinician tells a patient a diagnosis, some of them act on it right away, others put it off, others completely ignore it. And the latter group can be very frustrating to deal with. And I found I really enjoyed working with other doctors. And that's one of the things it takes to be a pathologist, I think, is enjoying the collegiality of other physicians. So that's, and another thing, particularly in my med school, the more exposure I had to the staff in internal medicine, the more I kind of didn't like them, just on a personal level. And the more exposure I had to the pathology staff, the more I liked them. So it was really kind of an emotional decision as much as a cognitive one. And of course, it might be in another med school, it might be just the opposite.
Right. Okay. Thank you, doctor. I appreciate it.
Thank you.
Brandon looks like a linebacker. Thanks, Brandon. Miriam.
Hi, can you hear me?
I can hear
Yes.
you.
Hi. Hi, Dr. Uthman. So as we were going through all the cases, I was just wondering, like, when you get a mass in your lab, and I was just wondering how you typically go about making a diagnosis. So you showed us first, like, the gross picture, and then more like microscopic views of the specimens. Is that typically what happens when you're making a diagnosis on a specimen that you receive?
Yes, that's standard for pretty much everything we do diagnostically. We get a specimen. Ideally, the specimen comes in from some outlying place with information, clinical information. Usually that's the weakest link. Some clients are good about providing that information. Others, you have to dig it up. But you get the specimen, you examine it with the unaided eye, you describe that's your gross description. Then it gets processed overnight, made into slides. You look at it under the microscope, you dictate the microscopic diagnosis, you sign the report, and that case is done.
Okay. Thank you.
Thanks, Miriam. Somebody needs to find out where Shane is. Shane is not in the lineup. Dr. Uthman, we have a fan favorite student who always comes on every week and asks a question, but she's not here tonight, and so somebody's got to find out where she is. Got to find out. Justin.
Hello.
Hello.
So, firstly, I wanted to say that this was really awesome. I was listening and I was like, oh, this is something that I think really suits me. So thank you.
That's great.
So my question is, so at the beginning of your talk, you mentioned all the, different kinds of pathologists. So how often in your line of work do you use that kind of that organic chemistry that tortures you throughout undergrad? Because, yeah.
And you can kind of generalize that question into how valuable are the basic sciences to a physician, not just a pathologist. Very valuable to me, completely worthless to others.
Yeah.
And I think is that I've just always loved science. And I never thought of the college experience as being just a rung to climb to get to be a doctor. I never thought of that. I wanted to go to college. I wanted to learn as much as I could about my major, which was biology, but I also wanted to learn about a lot of other fields in the humanities and in the social sciences. So I really applied myself. I went to a liberal arts college, and I just totally put the pedal to the metal all the way through. And then when I got to med school, I felt the same way about basic sciences. I really wanted to learn them. It's paid off for me. Now, there are other pathologists that don't ever think about it, and they probably are better than I am in pathology. But all I can say is it's really helped me. I think it's given me depth that I would not have had if I hadn't had those experiences.
Melanie. I think Melanie.
Hi. Yeah, can you guys hear me?
Yep.
Yes. Hi, Melanie.
Good afternoon. Thank you guys for being here and talking to us about this. The question I had is, have you ever dealt with any misdiagnosis? And if so, like, how you go about, does the specimen come back to you and then you have to run more testing, or how would that work?
Yeah, I mean, if you're asking, have I made misdiagnoses and made the wrong diagnosis? Yes. Fortunately, it's a very rare thing, and it is for most pathologists, because if you make them too commonly, you won't be a pathologist. But because, so much hangs on a pathologic diagnosis. Once the pathologist right? That is gospel. And so, yeah, we spend a lot of time making sure we're right, and you've got to be really obsessive compulsive to do it right. But no, everybody, people are people, and they make errors, and pathologists are no exception. And the way you deal with it is try to fix it as best as you can. So if you realize you made a misdiagnosis based on subsequent things that go on with the patient, then you go back and look at the slides, see where you went wrong. And if you did go wrong, then you issue an amended report. So you always want to be very honest and forthright about your mistakes. And people don't hold that against you, believe it or not. If you show that you're an intellectually honest person and that you'll always go the extra mile for them and their patients, you can weather those kind of storms. But yeah, it's something that always hangs over us. And we hate making mistakes, and we do everything we possibly can to avoid that. But yeah, it happens.
Thank you so much. And then, is it okay to just ask one last thing about COVID?
Sure.
Has your lab changed at all in regards to COVID specimens or anything like that, or is that not your focus area?
It's interesting. The clinical pathology part of my job, which we haven't talked about, it's mostly regulatory and administrative and stuff like that. It's kind of rote. This COVID stuff has been great. I'm so glad I didn't retire early, because I would have hated to have missed out all the clinical lab aspect on COVID. Yeah, so back when COVID was first described and first hit our shores, there was a lot of scrambling in the laboratory world and in the clinical world too, how to deal with it. And so there were a bunch of technical issues on dealing with those tests and determining what their effectiveness was, what their performance characteristics were. And yeah, that took up a lot of my time, and I loved it. And it turns out, so this is my last year of practice. My first year of practice was 1981, and that was the beginning of another great pandemic. That was AIDS, what became known as AIDS. So my whole career has been bookended by two great pandemics. And, as a physician, I'm glad I didn't miss them. And I'm going to regret the ones that I miss after I retire too. I'll be really jealous of the people that are still practicing when that next one hits.
Thank you.
Thank you. Awesome. Well, Dr. Uthman, that brings us to a close tonight. Thank you so much for your time and for sharing your wisdom with over 1,000 students here tonight. I think a couple of students commenting, Dr. Uthman is not saying the pandemics were great for the people, obviously, but from an academic standpoint, they are definitely good to learn from. That's how we continue to learn academically, how we continue to push science is having these pandemics. But obviously, we don't wish the pain and suffering on patients.
No, it goes without saying, I hope.
Yeah.
But they're professional challenges, and and it's, even though the things that professional challenges are called to take care of are unpleasant, somebody has to do it, and it's best for people that do it enjoy doing it.
Yep, that is true. Thank you so much for your time. I apologize to everyone for my crying the whole session. But we'll be back again next week. And Dr. Uthman, again, thank you for your time, and continue to go out there and help patients with your diagnoses.
Thank you. It's been a pleasure.
Yeah. Have a great night, everyone.